Now, what are the causes of type 2 diabetes? If you look at the inheritance, the risk of non-identical twins or siblings, chance of developing the diabetes is 25%. And the identical twins of the patients with type 2 diabetes have more than 50% chance of developing diabetes. So this is the typical pattern. If you look at type 2, it is a polygenic disorder. There are multiple genes which will ultimately decide the outcome in the form of type 2 diabetes. And unlike type 1 which has an HLA association, type 2 doesn't have, is the carry home message. Now, are there any environmental factors just like coxsackie B is important for type 1 diabetes? In the case of type 2 diabetes, low birth weight is very important predisposing factor. LBW babies in future, type 2 diabetes is more likely. Now, what is the clinical presentation? One simplest thing is urinary sugar report showing the presence of the glucose is the way people come to you by asking, am I diabetic? But remember, glycosuria is not diagnostic of diabetes. About 1% of population can still have renal glycosuria. And this condition called renal glycosuria basically occurs because of the low renal threshold for the glucose in these people. What prevents the glucose from entering urine? Even if the glucose enters through the glomerular filtrate, there is a tubular maximum. That is, it all gets reabsorbed. But in these people, that reabsorbing ability of the tubules is lesser. So that even at a lower level of the tubular maximum, the sugar will enter into urine. So there is a problem in these people. But one important feature clinically, if it is there, it is highly diagnostic of diabetes, that is retinopathy. If the retinopathy is there, then that is a very important telltale clinical feature, diagnostic of diabetes. Acanthosis nigricans in the physical examination is another important telltale sign of the diabetes. Now, one of the favorite questions of the examiner. What are the WHO criteria that you need to remember in order to make a diagnosis of diabetes? The three lucky numbers which you should not forget are 126, 140 and 200 milligrams per deciliter, if you want to remember about diabetes. So, WHO has proposed a very important criteria. Fasting plasma glucose more than 126 milligrams per deciliter, or random plasma glucose more than 200 milligrams per deciliter is an important criteria for the diagnosis of the diabetes. Then if you take the glucose tolerance test, if you do the glucose tolerance test, normal means fasting is less than 126, 2 hours after taking the glucose load is less than 140. Impaired tolerance, glucose intolerance, impaired glucose tolerance means fasting less than 126, but after taking the glucose load, after 2 hours if you check, if it is between 140 to 200 milligrams per deciliter, then you call it as impaired glucose tolerance. But if the fasting is more than 126 and after taking 2 hours of glucose load, if it is more than 200 milligrams per deciliter, then it is called as a florid diabetes mellitus diagnosed. So that's how you basically come to a conclusion. Now this is another, so these values 126, 140, 200, golden values which you should not forget. tomorrow in entrance, questions will be very simple, answers become complex if you don't know certain fundamental values. Now, what is the recommended diet? Once more, diet and diabetes is something related with the numerical values you need to remember when you go to the tomorrow's entrance exam. So, you need to be very clear. Protein, 1 gram per kg is the intake. Total fat should be less than 35% of the energy intake. And if you take the saturated and trans unsaturated fats, they should be less than 10%. PUFA, polyunsaturated fatty acids, must be less than 10%. And N6 type, whereas N3 polyunsaturated fatty acids, whatever the quantity you take is good. And mono unsaturated fat should be 10 to 20% only. Total carbohydrate, how much is permitted? Only 40 to 60% of the total energy intake should be total carbohydrate. And up to 10% of the total energy intake you can take in the form of sucrose. Any amount of fiber is good in case of diabetes. And alcohol is not forbidden. You can't say to a diabetic patient, stop alcohol today only. He will stop coming to your OP next day onwards. So, best thing is, alcohol is in moderation, not going to extreme is permissible. Salt should be less than 6 grams per day is considered to be a very, very important numerical value which you need to remember. Now, how do we treat diabetes? There are two kinds of treatment, tablet treatment, injection treatment. Basics. Now, you must know 5-6 points about each of these drugs, diabetic drugs, which is a favorite topic of the examiner. Both in pharmacology it is a high yield topic, and general medicine also high yield topic for the entrance exam. So, the first in the group you need to remember among the tablets is metformin, which is an example of a biguanide. How does biguanides basically act, doctor? They activate the enzyme AMP kinase, which is involved in the GLUT4 metabolism and fatty acid oxidation. It reduces the rate of gluconeogenesis and reduce the glucose output by the liver, and it will increase the insulin sensitivity in the peripheral tissues. Will it have any effect on the secretion of insulin? No, sir. That's the reason if you give any amount of metformin, there is no change in the insulin production. Hence, hypoglycemic episodes are never the problem with metformin. Hence, metformin is called euglycemic drug, is what you have to basically remember. And any drug that increases the insulin secretion will lead to weight gain. Why? Insulin is a lipogenic hormone. That's the reason any drug which increases the insulin secretion, any drug which increases insulin secretion is called secretagogue of insulin. That will lead to weight gain. That is never a problem with the metformin, is what you have to basically remember. And if your patient is overweight and obese and comes to you, what is the first drug that comes to your mind to prescribe him? Metformin is the drug that comes to your mind. So, this is a simple algorithm which you need to remember in relationship how the metformin functions. Phosphorylation and activation of the AMP kinase and decreased SREBP expression and decreased hepatic fatty acid and VLDL synthesis and decreased acetyl-CoA carboxylase activity and decreased hepatic glucose production and increased muscle glucose transport in the periphery by increasing the insulin sensitivity. By all these mechanisms, the metformin will be functioning. It has nothing to do with the insulin production, is what you have to fundamentally remember. Now, lot of times there is a debate. Is metformin more effective or sulfonylurea is more effective? So basically, metformin is as effective as sulfonylurea. In fact, the UK PDS study has clearly shown beyond doubt that if you use metformin, there is unexpected benefits when it comes to reduction of cardiovascular risk with metformin. So metformin and reduced heart attacks is the buzzword which you need to basically remember. And out of all the diabetic drugs, if at all there is one of the diabetic drug which is known to decrease the cardiovascular risk due to the diabetes, cardiovascular complications of diabetes, it is the metformin which has the distinction of being a drug which decreases the cardiovascular risk is what you have to basically remember. Now what are the side effects of the metformin, doctor? It can lead to development of epigastric discomfort and it can lead to development of diarrhea. They are the two problems with metformin. Now, sulfonylureas, they are called as insulin secretagogues. What do? They act on the beta cell and increase the secretion of the insulin, and typically if you take the sulfonylurea, they are never effective unless beta cells are present. That's the reason type 1 diabetic guys, they don't have beta cell mass. For them, the sulfonylureas become ineffective. Similarly, pregnancy, sulfonylureas are usually avoided in pregnancy is what need to be remembered. So how does sulfonylurea will act on the beta cell? So basically they will go, reach the cell membrane, they will make the ATP sensitive potassium channels are there, no? We already have discussed this. They block the efflux of the potassium out of it, and that in turn will increase the calcium levels inside the beta cell, and that lead to development of the release of the insulin and degranulation of insulin. So they basically do what GLUT2 stimulation will do. The same thing is done by sulfonylureas. GLUT2 receptor stimulation, if the glucose comes and binds with the GLUT2 receptors, we have studied, no doctor, that will lead to all the same changes. Rise of the intracellular calcium and degranulation and release of the insulin. Same thing is done by the sulfonylureas. What glucose will do by activating GLUT2 is done by the sulfonylureas on the potassium channels of the beta cells. That's what need to be remembered. So you have this pancreatic B cell. Mr. Sulfonylurea is coming, and that is what is Mr. Sulfonylurea doing? It is typically leading to the increase of the intracellular calcium concentration by blocking the potassium channel, and that lead to degranulation and release of the insulin, and hence it is called as insulin secretagogue is the name which is being given for it. But anything which releases the insulin, it has a lipogenic nature, hence weight gain is the issue with the sulfonylureas. For a long period of time, if you are constantly stimulating the beta cells to release insulin, that can promote the exhaustion of the beta cells, which can become a problem. So that is the reason if your patient is overweight already and comes to you, first drug that comes to your mind is metformin. Of course, if the sugars are not coming to control, we also add sulfonylurea. And since they release the insulin, they lead to hypoglycemia. That's the reason what will you tell to a guy who is taking sulfonylurea? After you take the drug within a short period of time, you need to have the food, otherwise hypoglycemia can occur. And two important precautions in using sulfonylureas. If the patient is having liver disease, sulfonylureas, you need to be careful. If the patient is having renal impairment, you should always check how is his liver. If already renal impairment, if it is there, Unless liver impairment is not there, you should not give sulfonylurea. And out of all sulfonylureas in the elderly people, which is the safest one? A quiz question in the entrance exam. Thalidomide is the safest in elderly because it has got a very short duration of action without the problem of hypoglycemic episodes. The next important drug among the diabetic drugs which you need to know today evening is thiazolidinediones. I am very happy. Some more of our online students, Dr. Nikhil and his classmates, they all have come online. I think since good number of you have joined, after this topic is over, we will take up one small quiz to wake you up from the sleep. Okay. What is the story of thiazolidinediones? It reduces the insulin resistance by interacting with one important enzyme called receptor called peroxisome proliferator activated receptor gamma, PPAR gamma. PPAR gamma is a nuclear receptor which will ultimately regulating a lot of genes involved in lipid metabolism and insulin action. So basically it will lead to, it interacts with this nuclear receptor called PPAR gamma is the function of thiazolidinedione, and that by interacting with it, it will decrease the insulin resistance in the periphery is what need to be remembered. So these are the thiazolidinediones which are acting on PPAR gamma, which in turn is a nuclear receptor, and that will in turn will affect the various genes associated with lipid metabolism. Now, if you are using the glitazone, one main advantage is there is a redistribution of the fatty tissue, so that the central adiposity will reduce, but peripheral fat will increase, and they will indirectly act on the glucose fatty acid cycle. They will lower the free fatty acid levels, and by doing so they will increase the consumption of the glucose by the muscle. See, the muscle ultimately when it needs energy, it gets energy from acetyl-CoA. Acetyl-CoA is produced either by the breakdown of the glucose or by the breakdown of the fatty acids. So what these thiazolidinediones are doing, they are basically lowering the free fatty acid levels. By doing so, the muscle has to naturally depend on glucose. So it will take up more and more glucose. So the sensitivity for uptake of glucose will increase in the peripheral tissues. How the free fatty acid levels are decreasing? By the action of thiazolidinediones, they act on the nuclear receptor. PPAR gamma is what need to be basically remembered. Now, if you use the glitazones will lower the circulating insulin compared to that of the plasma glucose, but they will not bring the glucose to normal. So if you give glitazone and wait for the glucose to normalize from 250 to 150, it doesn't happen. So there is a reason they are given as a add-on drug to a main drug like metformin or sulfonylurea, but not as a drug alone, standalone is what need to be remembered. Glitazones, they also reduce the hepatic glucose production. That's the reason if you combine them with metformin, they both can act like good colleagues to decrease the glucose production by the liver. And just like metformin, glitazones will also potentiate already released endogenous insulin. So that is one advantage of using the glitazones. Note the unwanted effects of glitazones. They can lead to weight gain, fluid retention, chance of developing heart failure, and congestive heart failure is very high. Very, very important side effect of glitazone which you should never forget. Favorite MCQ in the entrance exam. Fluid retention, risk of heart failure, glitazones. You have to remember in the tomorrow's exam. They can lead to osteoporosis and anemia. So that is what need to be remembered. So that's the reason. If a patient has heart failure, If his JVP is elevated, if he is having pulmonary edema, if he has got a pedal edema, heart failure patients, don't give pioglitazone or rosiglitazone is what you have to ultimately remember. Similarly, if a patient has got a ischemic heart disease, don't use rosiglitazone is a very, very important caveat which need to be remembered. Then comes meglitinides is another important group of drugs. Repaglinide, nartiglinide, they both are insulin secretagogues. What are these meglitinides? They are the non-sulfonyl urea moiety of the sulfonyl urea like glibenclamide. Glibenclamide is a sulfonyl urea. So, the non-sulfonyl urea moiety of it is being taken and being created into a drug called repaglinide and nartiglinide is what need to be remembered. So, just like sulfonyl ureas, how do they act? They go to the potassium ATP channel in the beta cells and they inactivate it and increase the intracellular calcium and lead to degranulation of the vesicles and release the insulin. That's what we discussed now. Same thing is done by the meglitinides also is what need to be basically remembered. But unlike the glibenclamide or any sulfonyl urea which are more long acting, the repaglinide, nartiglinide, they are short acting in nature. So there is an advantage and they typically promote the insulin secretion in response to the food. So they are called as insulin secretagogues. Now few injection therapies we need to know. 3-4 comments about each of these injection therapies is a favorite topic of the examiner. Incretins. So what is meant by an incretin effect? Typically whenever you take the glucose orally versus intravenously, if you observe, the insulin production in response to oral glucose will be more than the insulin production in response to intravenous glucose. This effect is called as incretin effect. And what is the reason for it? If you orally take glucose, it will cause the release of what is called as glucose dependent insulinotropic peptide called the GIP and GIP. It will also lead to glucagon like peptide called GLP-1 from the L cells in the intestine. There are a type of cells called L cells in the intestine. They release it. And due to the release of this GLP-1 and GIP, the amount of insulin produced in response to oral glucose is more than the intravenous glucose, which is called as incretin effect is what you have to basically remember. Now, if you take type 2 diabetes, what is the problem in him? This incretin effect, whenever we eat a nice jalebi or laddu, we expect that laddu to stimulate the GLP-1 and GIP and cause more amount of insulin production. So, that incretin effect is diminished in these guys who have the type 2 diabetes. So, this GLP-1, it has got a very short half-life. So, we want to create an analog to that called as exenatide and liraglutide, which are the longer acting analogs of GLP-1, which typically will enhance that incretin effect, which is missing factor in the case of the type 2 diabetic individuals, is what need to be remembered. So how do you give exenatide? Exenatide is basically administered twice daily, subcutaneous injections which will promote the release of the insulin. It will inhibit the release of the glucagon. It will reduce the appetite. It delays the gastric emptying and it will blunt the postprandial rise of the glucose after you take food. So they are all the effects of this exenatide is what need to be remembered. So this graphic will give you in short summary what are the mechanisms of action of GLP-1. So reduce food intake, enhanced insulin secretion, delayed gastric emptying, decreased hepatic glucose production, and improving the ultimately fasting and postprandial glucose levels is the effect of GLP-1. And you need to remember exenatide, which is the long-acting analog of the GLP-1. But you need to give it subcutaneously. That's the main disadvantage if it is not a orally taken tablet. But its advantage is it won't lead to weight gain. So, it will improve the glucose control at the same time by decreasing the appetite, delaying gastric emptying, it promotes the weight loss. But in few people, acute pancreatitis is one of the side effects reported with exenatide. At present, it is considered to be an alternative to insulin, particularly in the people who are already overweight. Because if he is an overweight guy, if you are giving insulin, insulin itself being lipogenic will lead to problems. So there is a reason the exenatide will not let the weight gain to happen, is what you have to ultimately remember. Then we have dipeptidyl peptidase 4 inhibitors. DPP4 inhibitors is the next group of drugs. So what is DPP4 basically? We said that to mediate a incretin effect, GLP-1 is released by the L cells of the intestine when you orally take the glucose. So there is one enzyme called dipeptidyl peptidase 4 which is known to break down the GLP-1. We want a breakdown of GLP-1 or we want GLP-1 to be more to overcome the diabetes, we want it to be more. So how can you do that? You can give an inhibitor of this dipeptidyl peptidase 4 and that in turn will lead to the inhibition of the breakdown of the GLP-1 and increase the levels of GLP-1, which typically has got that incretin effect is what need to be basically remembered. So which are the drugs which are called as dipeptidyl peptidase 4 inhibitors, doctor? Sitagliptin, vildagliptin are called as dipeptidyl peptidase 4 inhibitors. So just like the exenatide, which is a GLP-1 analog, which lead to reduction of the weight, the same effect is even there for the sitagliptin and vildagliptin is what need to be remembered. So this is a very, very important pictorial which will summarize you the whole story. Once you have taken orally the glucose will come to the small intestine and the small intestine border will increase the release of GLP-1 and GIP. Normally that is being broken down by the DPP4. But if you give a DPP4 inhibitor, it will not be broken down. Then if the levels of it increase, that will have an effect on the pancreas and that will cause an increased insulin, decreased glucagon, decreased glucose production by liver and all the incretin effects typically will be there. So in which group of people is this very good? Those who have early stages of type 2 diabetes, in whom the insulin secretion is still relatively preserved, in them these drugs are very, very effective. But the main side effect of sitagliptin etc. is the nausea. Now the next important drug would be acaribose. Acaribose is basically an inhibitor of the intestinal enzymes. It will competitively inhibit the alpha glucosidase in the brush border of the intestine and that prevents the carbohydrates consumed by the patient from getting absorbed from the intestine. But those undigested grass we eat as vegetarian, as one of our patients used to say, will be broken down by the small intestinal bacteria and release a lot of gas. That gas will produce flatulence, abdominal discomfort, diarrhea. There are all the problems with acaribose. Acaribose is a drug hated by the patients because of all this flatulence and other important side effects. Then another favorite question of the examiner is orlistat. What is orlistat, doctor? It is the lipase inhibitor which reduces the absorption of the fat, and it typically benefits the diabetics by promoting the weight loss, and all that fat which is no more absorbed will be lost into the stool, and that can lead to unpleasant steatorrhea, which can be the problem with the orlistat. So orlistat is a lipase inhibitor is what need to be fundamentally remembered. Rimonabant. What is the importance of this very important drug? So I am very happy our other online students, Dr. Fahima, etc., they have joined the game a little late, no problem. So in a live class, we have a feeling that we are a little late to the class. But a synchronous online class, you can be a little late and still say good evening to all your classmates. Even teacher can come a little late, but ultimately we all can be part of the learning process. Any doubt we get, we can ask, please repeat sir, we did not understand. Or if we love to have some clarification on a point, we can instantly ask the teacher. So that is the beautiness of the modern synchronous learning process. You can also chat with your other classmates online. Anything is possible in this informal synchronous learning on the online platform. So the future of education is all e-learning. If you don't have internet, now the new option that we are giving to the students is, we place all this video library lectures onto a tablet. But this tablet comes for some 4,000-5,000 rupees. So we will load it in a SD card and give to you. You can put it, and then without internet, without computer, you can sit in the reading room and plug in and then listen whichever the lecture. But that is asynchronous learning. You have to be self-motivated to learn through the videos. Whereas synchronous, you can be able to learn with the videos. You can be able to learn asynchronously at your own comfort. Nowadays, tablets are revolutionizing the learning process. But anyway, rimonabant is our next drug. We invite our online other classmates, Nina, etc., etc. So without meeting all of you, the day doesn't end, doctor. So we need to discuss some topics, some questions, some quiz, and say that we are in the momentum of preparation for the entrance exam. And also, you always have the complete video library which is available anytime, any video, whichever is your choice, you can be able to review. So that's the whole idea. So rimonabant is a cannabinoid that promotes the weight loss in the type 2 diabetics. And you will keep on telling a patient of diabetes, aloo mat khao, roots don't khao, rice mat khao. Ultimately patient will say, if I don't eat anything, why to live? Let me die. Patients will go into depression if you restrict them from eating according to their own love and passion. Now, yes, I think Deva has a valid point that the Facebook upload was not done. Just by tomorrow we will do that. Thanks for reminding. That went out of notice. Yeah. Now, rimonabant is not routinely used. It is mainly used to people who experience a mood fluctuation in a strict dietary regime, and it is also helpful in the patients who go into weight gain once they are being started on insulin or any secretagogue. Now comes a very important part of our discussion in diabetes, which you have to be very sure. Short acting insulins, intermediate acting insulins, you need to be 100% sure. One question, doctor, out of 30 questions in general medicine will be from diabetes. If you miss it here, you will definitely have it in pharmacology, because in pharmacology, high yield topics, once more, diabetic drugs, insulin is a favorite topic. So, short acting insulins, they are typically used as a pre-meal injection in the multiple dose regimes, and they are also used for the continuous intravenous infusion in medical emergencies like diabetic ketoacidosis, or a patient who is in labor and the patient who is on insulin pump, they use the short acting insulins. So human insulin, it is absorbed slowly, it reaches a peak in 60 to 90 minutes, and it is given as a subcutaneous injection, and its action will persist a little long after the meals, and it can predispose to hypoglycemia. Now, if you look at the insulin, the absorption of the insulin is delayed because the regular insulin or a soluble insulin, which you call, is in the form of a stable hexamers. That is 6 insulin molecules around a zinc core, and it needs to dissociate before it shows its action, and that is the reason the absorption typically become delayed. Now, if you look at short acting insulins, we can use a lot of insulin analogs. So what is the purpose of the insulin analogs? If you take the regular insulin, it will take a little time for it to dissociate and get absorbed. So we can overcome that by slightly engineering the molecule. Insulin lispro, insulin aspart, insulin glulicin. So these are the ones which enter the circulation more rapidly than the human soluble insulin, and they will also disappear more rapidly. And if you look at the short acting insulin analogs, what are they? Insulin lispro, insulin aspart, insulin glulicin. So these are the ones, they are very quick in onset, quick in offset. That's the reason, if you look at the overall glucose control, they don't have much of an effect. They are like that item number who just dances in the movie and goes away. She is not heroine, only an item number. Of course, there are heroines who act like item numbers. So, short acting insulin analog like insulin lispro is an item number in a movie who dances and goes away. So, we use a combination generally. For example, 75-25 means 75 is the protamine, which is a little more long acting or intermediate acting, and you have a lispro which is more rapid onset in action. So 75-25 kind of combinations. Then we have longer acting insulins, which we need to basically remember. If you add zinc or protamine is derived from the fish sperm, then it becomes little long acting. So you have isophane insulin, which is called NPH insulin. And what is the advantage of this NPH insulin? NPH acts like a longer acting one, and it can be combined with the soluble insulin, which is the regular insulin, which is a short acting one, and it can be given as a mixture. So generally we give 70% NPH with 30% regular short acting insulin. So that is a combination which we give. And the long acting analogs, they are basically engineered in such a way that their absorption becomes delayed and their duration of action is much more prolonged. So, insulin glargine and insulin detamir, they are the examples of the long acting insulin analogs. Glargine insulin is a soluble in a vial in a acidic pH 4 solution, and it precipitates at the subcutaneous pH and it prolongs the duration of action. That is the principle of prolonging its duration. Insulin detamir, it has got a fatty acid tail which will enable it to bind with the serum albumin, and since the dissociation of it from the serum albumin takes time, the duration of its action also become little prolonged. So the glargine and detamir are the long acting insulin analogs is what need to be remembered. Whereas NPH is that intermediately acting one. And if you look at the insulin glargine or detamir versus NPH, is there any more advantage of using glargine or detamir compared to NPH as a long acting partner in the mixed preparation of insulin? That is my question to all of you. So, the glargine and detamir, they have very little advantage over that of the NPH in most of the situations. And since they are more long acting, hypoglycemic episodes are possible. That is the reason we need to be little careful. So now, what is the philosophy of management of a patient of diabetes is a very, very important question. First thing is, when a patient is diagnosed with the type 2 diabetes, lifestyle modification. You must tell him that he reached the afternoon of his life. There is still a evening and a dinner, supper, midnight, moonlight is waiting. So don't deteriorate yourself. So the guys who were not walking and jogging, you must ask them to spend time in walking and jogging. Those who are smoking like the furnaces, ask them to bring down the cigarettes. So lifestyle modification plus metformin. Now, most of the times by lifestyle modification and metformin, they will stop decreasing the amount of carbohydrates in their food. They will start jogging a minimum of half an hour and they take metformin, problem solves. But if the HbA1c remains more than 7%, you need to add sulfonylurea. Or you can add a basal insulin, or you can add a glitazone to the metformin. In spite of that, if the HbA1c is more than 7%, then you need to combine. Sulfonylurea already added means you need to add glitazone and insulin. And he is already on insulin means you need to intensify the insulin. If he is already on glitazone, you need to add insulin and sulfonylurea. Then still if the HbA1c is more than 7%, you need to further intensify the insulin regime and then you need to combine ultimately insulin, metformin, glitazone and see to that the glucose levels are brought to normal. So, the type 2 diabetes, already we discussed DKA, which is the main complication of type 1. Sometimes type 2 people also can go into decay. Suppose if they have heart attack or stroke, a type 2 diabetic also can go into decay. But in type 2, one of the challenging complications which can occur, very good. Deva is saying, just like sulfonylurea resistance, is there any resistance to metformin? Basically, it's not a question of resistance. For the sulfonylurea to act, it needs to act by increasing the release of insulin. So a type 2 diabetic individual at the age of 40 who has got abundance of beta cells, by the time he becomes 55, 56, constantly taking the sulfonylurea will develop an apoptosis of the beta cells and can become sulfonylurea resistant. But metformin's mechanism is not dependent on the release of the insulin. It will go and act on the liver. So there is a reason the chances of developing a resistance to the metformin are less likely than that of what happens with the sulfonylurea. I hope that answers Deva's question. Now, hyperosmolar hyperglycemic state is a very important topic of type 2 diabetes complications we are now going to talk about. When you call hyperosmolar hyperglycemic state without developing ketoacidosis, if there is a severe hyperglycemia in an uncontrolled type 2 diabetes, you call it as hyperosmolar hyperglycemic state. Typically, it presents in the middle to later part of the life. A good number of times when a patient of type 2 diabetes is admitted, Nurse Mary had been giving him a lot of 5% dextrose for some other reason, for malaria or diarrhea, he got admitted and he is receiving a lot of glucose rich fluids. Or suppose if he is a diabetic type 2 who is on antihypertensive therapy with thiazides, or he is receiving steroids, or if there is an intercurrent illness, then the hyperglycemia can be severe enough to lead to hyperosmolar, hyperglycemic state is what need to be basically remembered. Now, if you look at hyperosmolar hyperglycemic state versus ketoacidosis, extreme dehydration is the characteristic feature of this hyperosmolar hyperglycemic state. And older the person, the greater the chance of his landing up in hyperosmolar hyperglycemic state. And if there is a mild renal impairment associated with the age, that's more likely to worsen the fluid electrolyte disturbances and precipitate a hyperosmolar hyperglycemic state. And the amount of insulin deficiency, if you look at ketoacidosis, diabetic ketoacidosis may jada insulin deficiency, lot of insulin deficiency is there. That is not the case in case of hyperosmolar hyperglycemic state. Generally, endogenous insulin production in a patient with hyperosmolar hyperglycemic state are sufficient enough that it prevents the development of ketogenesis in them, in spite of hyperglycemia. Patients present with dehydration, stupor, coma, and there is a state of hyperosmolarity. Commonly predisposing factors like pneumonia, pyelonephritis will be there, and this hyperosmolar state can increase the procoagulant tendency and can precipitate stroke, MI, arterial insufficiency in the lower legs, etc., etc. Now, in this paper, if you look at the plasma osmolarity in hyperosmolar hyperglycemic state, it is very, very high. So, what is the formula for calculating plasma osmolarity, doctor? 2 into sodium plus potassium plus glucose plus urea, all in millimoles per liter. And these people, if you initiate insulin, drastically there is a fall of the glucose levels and they are very, very insulin sensitive. That's the reason, don't be too aggressive in lowering the glucose levels in a patient of hyperosmolar hyperglycemic state. If you do that, if there is a drastic fall down of the glucose, suddenly the fluid will move from the brain to the CSF or from CSF into the brain, and such sudden changes can lead to cerebral damage, which can be a little dangerous. That's the reason, what is the recommendation to administer insulin in hyperosmolar hyperglycemic state people? Infuse insulin at a rate of 3 units per hour for the first 2 to 3 hours. Increase it to 6 units per hour if the glucose is falling too slowly. And you need to give 0.9% saline, just like in DKA patients, and try to avoid half normal saline like 0.45%. So that is a very, very important principle. But if you take hyperosmolar hyperglycemic state, the mortality can be very high as 20 to 30%. Mainly because hyperosmolar hyperglycemic state is a problem more often in the elderly people with type 2 diabetes. And elderly people obviously have a poor renal function, and the chance of mortality is much, much higher in them. And if you take diabetic ketoacidosis people, 1 episode of diabetic ketoacidosis, if it is there, then it is an indication for them forever to take insulin after that also, instead of oral tablets. Whereas hyperosmolar hyperglycemic state, if 1 episode happens, after the episode subsides, by itself is not an indication for a long-term insulin therapy. You can once more continue on the same metformin and sulfonylurea. So that is a very important point to be understood. So let us look at a quick comparison graph between DKA versus hyperosmolar hyperglycemic state. Of course, here everything is mentioned in millimoles per liter. If you look at the pH, it is acidotic in ketoacidosis but more or less normal, 7.35. in case of the hyperosmolar, hyperglycemic people. Sodium will be almost 155, and if you look at the glucose levels, it is 30 millimoles per liter in DKA patients, and it is nearly 50 millimoles per liter in case of hyperosmolar hyperglycemic state. Very, very high. And if you look at the bicarb, it is well preserved in hyperosmolar but exhausted, low bicarb, due to the diabetic ketoacidosis. So these are the fundamental differences which you need to appreciate. So doc, in summary, we understood what is all the diabetes is about. Type 1, type 2 and the various diabetic drugs, which is the favorite question topic of the examiner. 2 minutes we will be out of video to take a backup. Stay online. We will have a discussion on the quiz, and we will take up one more topic, diabetic complications, and then call it off, sign out of the today's evening. Please be online. 2 minutes will be up, back with the video.